Succeeding topics will focus on the major types of idiopathic inflammatory myopathy, systemic sclerosis, and mixed connective tissue diseases. Idiopathic inflammatory myopathy is a heterogeneous group of disorders characterized by symmetrical proximal muscle weakness with elevated serum levels of muscle enzymes such as CK, aldolase, ALT, AST, and LDH. Creatinine kinase is the most sensitive laboratory test for muscle destruction. However, not all myopathy is associated with elevated creatinine kinase, but a markedly elevated creatinine kinase is almost always due to a myopathy. EMG-NCV, on the other hand, is good for localizing the lesion, while biopsy is needed to distinguish one type of myopathy from the other. It is very important that we choose the muscle that is clinically symptomatic but generally not too weak. So for the clinical features, patients with myositis or myopathy will present with symmetrical muscle weakness except in inclusion body myositis, and most of the time the affected muscles are the proximal muscle groups and the distal muscle groups are usually affected later. The pharyngeal neck flexor muscles as well as the respiratory muscles may also be involved. Previously, these three are classified as the major types of myopathy. Polymyositis and dermatomyositis has a female predominance, but polymyositis may occur in late teens to older with a mean age of 50 to 60 years old, while dermatomyositis has two peaks, 5 to 15 years and 45 to 65 years old. IBM or inclusion body myositis, on the other hand, has a male predominance which may occur in older individuals of more than 50 years old. So this is the criteria for the diagnosis of polymyositis and dermatomyositis, which are the two more common types of myopathy. So we have symmetrical muscle weakness affecting the proximal muscle groups. We have the muscle biopsy showing perivascular atrophy and perivascular inflammation, elevation of muscle enzymes, electromyographic evidence of the triad of short, small, polyphasic motor units, fibrillations with positive sharp waves, and insertional irritability. And in dermatomyositis, there are characteristic dermatologic features such as the heliotrope and the Gauthron sign. Dermatomyositis is a type of myopathy that has a characteristic rash that either accompanies or precedes muscle weakness. Heliotrope rash and the Gauthron signs, or rather the Gauthron's papule, are the two pathognomonic lesions or skin lesions for dermatomyositis. Heliotrope rash is the violaceous discoloration on the upper eyelids of the patient, while the Gauthron sign is the erythematous rash over the extensor surfaces of the joints such as the knuckles and the elbows, while the Gauthron's papules are the elevated erythematous rash over the knuckles of the patient. The V sign and the Scholl sign are the erythematous rashes over the sun-exposed areas on the neck and the upper chest, and the Scholl sign is on the back and shoulders. We also have dilated capillary loops at the base of the fingernails, and the mechanic's hands are the hyperkeratotic scaling or fissuring, especially on the radial side of the fingers. This is more commonly seen in patients with antisynthetase. Dermatomyositis may also be seen in overlap syndromes, usually with other connective tissue diseases such as scleroderma and Mctd. This is also the more commonly associated with malignancy, especially those patients acquiring these myositis-specific antibodies such as anti-NXP2 and anti-TIF1. So this picture shows the characteristic heliotrope rash, the reddish purple or the violaceous discoloration on the upper eyelid of the patient. This is the Gauthron's rash, the erythematous rashes over the knuckles or the extensor surfaces of the hands of the patient, the mechanic's hands, the dilated capillary loops, and the V sign over the upper chest of the patient. Polymyositis is a subacute symmetric proximal inflammatory myopathy where muscle weakness usually worsens or progresses over several weeks to months. This is just like dermatomyositis without the characteristic rashes. This affects adults and rarely seen in children. It may also be associated with other connective tissue diseases and is less commonly associated with malignancy. On the other hand, inclusion body myositis is usually seen in older individuals more than 50 years old with a slightly more male predominance. This type of myopathy has an asymmetric muscle weakness and presents with muscle atrophy with predilection to involve the wrists and finger flexors in the arms and quadriceps muscles in the legs even early in the disease course. This has no known risk for malignancy, and creatinine levels may be normal or slightly elevated. So this slide shows the different characteristic histopathologic findings between the three major types of inflammatory myopathy. But in general, you will see necrosis, regeneration, degeneration, variation in the fiber diameter, and an increase in connective tissue and inflammation. However, in dermatomyositis, you will appreciate loss of capillaries with capillary necrosis with complement deposition and perifascicular atrophy, which is the most pathognomonic histopath findings. However, only one-third of patients will show this. CD4 T cells and macrophages and B cells in the perivascular distribution are the predominating inflammatory cells in dermatomyositis. There is also class 1 MHC, which has a patchy and perifascicular staining. In polymyositis, macrophages and activated CD8 T cells invading the non-necrotic muscle fibers in the endomysial areas are the predominating inflammatory cells in polymyositis. On the other hand, inclusion body myositis, we will appreciate red rim vacuoles and inclusion bodies and amyloid deposits, also with mononuclear invasion in the non-necrotic muscle fibers in the endomysial areas. It is imperative that we do biopsy in patients whom we suspect to have polymyositis to exclude the possibility of inclusion body myositis. So the succeeding slides will be about the two new added types of inflammatory myopathy. So we have the immune-mediated necrotizing myopathy, which has an acute or insidious onset of symmetric proximal inflammatory myopathy and is usually associated with statin use, affecting older individuals. However, it may also be seen in younger individuals, even in children, without history of prior statin use. This is usually associated with anti-HMG-CR, particularly those with history of statin intake, and anti-SRP specific antibodies are also seen in those patients without prior history of statin use. CK levels are markedly elevated, and histopathologic finding shows multifocal necrotic and regenerating muscle fibers with paucity of inflammatory cells. So this another type of inflammatory myopathy is the anti-synthetase syndrome, which is associated with the presence of myositis, non-erosive arthritis, ILD, Raynaud's phenomenon, mechanics, hands, and fever. This is associated with anti-synthetase antibodies, most commonly the anti-Jo1 or the antibodies against the amino acyl tRNA synthetase, and biopsy shows predilection of perimysial damage and perifascicular muscle fiber necrosis. So for the treatment, we use high-dose glucocorticoids, either oral or IV, and IV methylprednisolone is used in those patients who present with severe muscle weakness and those with comorbidities. Second-line therapy, such as the following, are used in those patients whom we cannot taper steroids or those who are non-responsive to steroids. So the following are azathioprine, methotrexate, mycophenolate mofetil, which is an option in patients with ILD, as well as in tacrolimus cyclophosphamide. Rituximab is also an option in those patients with refractory myopathy, and IVIG, those patients who are refractory to steroids and at least one immunosuppressant or at least one second-line treatment, and those patients with positive anti-HMG-CR myopathy. So as mentioned earlier, inflammatory myopathy is associated with malignancy, particularly dermatomyositis. So the most common tumors associated are also the common tumors as seen in the general population, either male or female. Next, we have systemic sclerosis. Systemic sclerosis is an autoimmune condition that has a sporadic distribution and a strong female predominance, particularly of childbearing years. It has multisystem involvement with heterogeneous clinical manifestations that has the tendency to have chronic and often progressive course that leads to significant disfigurement, disability, and mortality. There are multiple genes that contribute to disease susceptibility, but genetic contribution only make up a small percentage. Hence, environmental exposures are likely to play a major role in causing scleroderma. The early stage of systemic sclerosis is associated with prominent inflammatory features. Over time, the fibrotic phase predominate that leads to functional and structural alterations in multiple vascular beds and progressive visceral organ dysfunction. Thickening of the skin is the hallmark of systemic sclerosis, which can also occur in localized forms of scleroderma and other disorders. Scleroderma is further divided into two types, the limited and the diffuse scleroderma, which is based on the pattern of skin involvement, clinical and laboratory features, and its natural history. The diffuse scleroderma has a more advancing skin involvement and has a clinically important asymptomatic organ involvement during this phase. It tends to involve early the face, the trunk, and the extremities, while the limited scleroderma has a more indolent course, which only involves skin thickening of the face, the distal extremities, particularly below the elbows and below the knees. These are the main differentiating points between the two subsets of systemic sclerosis. So based on skin involvement, limited cutaneous scleroderma is limited to the fingers, distal to elbows, face, and a slow progression, while diffuse cutaneous scleroderma has a rapid onset, and it tends to involve early the fingers, the extremities, the face, and the trunk with rapid progression. Raynaud's phenomenon antedates the skin involvement in limited scleroderma, while it is coincident with the skin involvement in patients with diffuse cutaneous scleroderma. However, critical ischemia is less common. Musculoskeletal involvement is more severe in diffuse scleroderma, and ILD is more frequently seen, particularly early in the onset, and is more severe in patients with diffuse scleroderma. However, pulmonary hypertension is more frequent in limited cutaneous scleroderma and may occur as an isolated complication. Scleroderma renal crisis is very rare in limited cutaneous scleroderma, but calcinosis cutis is more prominent and more frequent in limited scleroderma. Characteristic antibodies associated with limited cutaneous scleroderma is anti-centromere, while anti-topoisomerase 1 and anti-RNA polymerase 3 is more associated with diffuse cutaneous scleroderma. So these are the different types of localized scleroderma. So we have the guttate morphea, which are small multiple sclerotic lesions typically found in the neck and upper chest. We have the hemifacial atrophy that involves atrophy of the subcutaneous tissue, the fat, and the muscles on one side of the face, giving a sunken appearance, while bullous morphea is a subcutaneous bullae overlying the deep or linear morphea, and queue de Sabre is a pansclerotic plaque restricted to the frontoparietal region and is commonly seen in children and in women. On the other hand, These are the other conditions that may also present with skin induration. So again, systemic sclerosis is an acquired sporadic disease with worldwide distribution affecting all races. It has a strong female predominance with the peak age of onset for both limited and diffuse cutaneous forms is 30 to 50 years old. Given the relatively modest genetic contribution to disease susceptibility, environmental factors are likely to play a major role causing scleroderma. So patients with scleroderma show evidence of chronic infection, particularly of Epstein-Barr virus. Occupational exposures are also tentatively linked to scleroderma, and certain drugs are implicated in having scleroderma-like illnesses. Silicone breast implants in women have been shown or have been linked in scleroderma, but epidemiological studies showed no evidence of increased prevalence of scleroderma in these patients. But it is important to note that smoking is not considered a risk factor in the development of scleroderma. The three cardinal pathophysiologic processes that accounts for the clinical presentation of scleroderma are diffuse microangiopathy, inflammation and autoimmunity, visceral and vascular fibrosis in multiple organs. Autoimmunity and the altered vascular reactivity are early in the manifestation, and complex and dynamic interplay between these processes initiates and amplifies the fibrotic process. The initial presentation between the two types of scleroderma is quite different. Diffuse cutaneous scleroderma has two phases: the inflammatory edematous phase, wherein patients will present with soft tissue swelling, intense pruritus, and diffuse skin hyperpigmentation and carpal tunnel syndrome. Arthralgias, muscle weakness, fatigue, and decreased joint mobility are also common during this phase. During the ensuing weeks to months, the inflammatory edematous phase evolves into the fibrotic phase, with skin induration are more prominent, associated with hair loss, reduced skin oil production, decline in the sweating capacity, presence of flexion contracture of the fingers or sclerodactyly, and stiffness of the joints. While advancing skin lesion is most visible in the early stages of diffuse scleroderma, it is important again to note the clinically silent involvement of internal organs during this stage. So comparing to diffuse scleroderma, the course of limited cutaneous scleroderma is more indolent. The interval between Raynaud's phenomenon and the onset of manifestations such as GERD, cutaneous telangiectasia, and soft tissue calcifications may occur after several years. Raynaud's phenomenon is the most frequent extracutaneous complication of scleroderma that is due to episodes of reversible vasoconstriction in the fingers and toes. But it can also be observed in the tip of the nose and their earlobes, and it is usually triggered by a decrease in temperature and emotional stress and vibration. Raynaud's phenomenon has three phases: pallor, that is due to vasoconstriction, cyanosis secondary to ischemia, and hyperemia because of reperfusion. Raynaud's phenomenon can either be primary, that is supported by the absence of underlying cause, a family history of Raynaud's phenomenon, absence of digital ulceration, and a negative ANA test. While secondary Raynaud's phenomenon usually develop in an older age group, is clinically more severe and is more associated with ischemic digital ulcerations. But the main differentiating point between the two is doing nail fold capillaroscopy, that in primary Raynaud's disease, you will see a normal capillaries that appear as regularly spaced parallel vascular loops, while in secondary Raynaud's phenomenon, the nail fold capillaries are distorted with widened irregular loops and appearance of vascular dropouts. So the main utility of nail fold capillaroscopy is to visualize the nail fold capillary bed that helps distinguish between primary and secondary Raynaud's phenomenon, and it also helps to establish the diagnosis of scleroderma during the early stages. Abnormalities in the nail fold capillaroscopy are positively correlated with diffuse form of scleroderma, the degree of cutaneous involvement, and the presence of anti-SCL70. The early stage of scleroderma is characterized by the edematous phase that progresses to bilateral symmetrical skin thickening, which is the hallmark of scleroderma. It usually starts in the fingers, advancing in ascending fashion. There's also dermal sclerosis that obliterates the hair follicles and the sweat glands, leading to hair loss, decreased sweating, and dry skin that leads to intense pruritus. Transverse creases of the dorsum of the fingers also disappear. There is the presence of fixed digital peats, appearance of dystrophic calcification called the calcinosis cutis, which is usually associated with long-standing anti-centromere positive limited cutaneous scleroderma. Telangiectasias may also be observed in these patients. So this is how salt and pepper skin appearance looks like. It is due to the pigment loss that spares the perifollicular areas that is commonly observed in the scalp, the chest, and the upper back. Scleroderma also has a certain facet called the Moscow appearance, where the skin appears to be taut and shiny and expressionless. This is due to the limited mobility of the eyelids, the cheeks, and the mouth, and there's thinning of the lips, loss of wrinkles, big nose, and presence of fine wrinkles around the mouth. Patients with scleroderma, particularly limited cutaneous scleroderma, presents with sclerodactyly or the flexion contracture of the fingers that may also involve the wrists, the elbows, and the knees. There may also be acroosteolysis that is seen in radiograph that is due to the dissolution of the terminal digital phalanx because of ischemia. Pulmonary complications in scleroderma is the most common cause of morbidity and mortality. Among the two most common is interstitial lung disease, particularly nonspecific interstitial pneumonia that is frequently associated with diffuse scleroderma, and pulmonary arterial hypertension frequently occurs in limited cutaneous scleroderma. Pathologic processes can be found at any level of the gastrointestinal tract, and 90% of the patients will have gastrointestinal involvement in scleroderma for both the limited and diffuse cutaneous forms. So patients may have reduced oral aperture. There may be decreased peristaltic activity because of the collagenous replacement of the normal intestinal architecture. There may be chronic GERD or gastroesophageal reflux disease due to chronic inflammation and mucosal ulcerations. There may be gastroparesis and presence of gastric antral vascular ectasia or watermelon stomach. Scleroderma renal crisis occurs in around 10 to 15% of patients and generally within the 4 years of onset of the disease. So prior to the advent of ACE inhibitors, there is only short-term survival of these patients of less than 10%. So the pathogenesis of scleroderma renal crisis involves obliterative vasculopathy and luminal narrowing of renal arteries. The risk factors are said to be African American race, patients who are males, and those patients with diffuse scleroderma with extensive and progressive skin involvement. Around 50% of the time, patients with scleroderma renal crisis has a positive anti-RNA polymerase III antibodies. On the other hand, in patients with limited cutaneous scleroderma can also develop scleroderma renal crisis, but is most commonly associated with glucocorticoid use. These patients usually present with accelerated hypertension and progressive oliguric renal insufficiency. However, a certain percentage of patients who are experiencing scleroderma renal crisis will have a normal blood pressure. Urinalysis in scleroderma renal crisis typically shows mild proteinuria, presence of granular CAS, and microscopic hematuria. Thrombocytopenia and microangiopathic hemolysis with fragmented red blood cells can also be seen and may be harbinger of impending scleroderma renal crisis. Cardiac involvement in scleroderma is more frequently seen associated in diffuse scleroderma. It may either be primary or secondary to pulmonary complications such as ILD, PAH, and or renal involvement. So the clinical manifestations are more prominent to involve the myocardium and the pericardium of the heart. So for the other disease manifestations, patient may experience Zika syndrome, hypothyroidism, and sensory trigeminal neuropathy. Patients may also have erectile dysfunction and sexual performance impairment, especially in females, while the CNS is generally spared and fertility is not affected. So for the laboratory evaluation, anemia may be variable from mild normocytic to microcytic anemia because of GI bleeding caused by gastric antral vascular ectasia. Patient may also have macrocytic anemia due to folate and vitamin B12 deficiency because of small bowel bacterial overgrowth and malabsorption, and also hemolytic anemia due to microangiopathy. ESR is usually normal in patients with scleroderma, and these patients may also have a positive ANA. So other serologic or presence of other autoantibodies may be observed, particularly anti-topoisomerase 1 associated with ILD in diffuse scleroderma, anti-centromere antibodies associated with pulmonary arterial hypertension in limited cutaneous scleroderma, and anti-beta 2 glycoprotein 1 that puts the patient at risk for developing ischemic lesions in the fingers, and other autoantibodies are anti-U3RNP and anti-RNA polymerase 3. So this is the classification criteria for the diagnosis of scleroderma, wherein we take note of the presence of skin thickening, the fingertip lesions, mucocutaneous telangiectasia, abnormalities in the nail capillary pattern, presence of lung involvement, Raynaud's phenomenon, and for the presence of specific autoantibodies. For the treatment, to date, no therapy has been shown to significantly alter the natural history of scleroderma. But in contrast, multiple interventions are highly effective in alleviating the symptoms, slowing the progression of organ damage, and reducing disability. A significant reduction in disease-related mortality has been noted during the past 25 years. Optimal management should incorporate the following principles: prompt and accurate diagnosis and early recognition of organ-based complications, regular monitoring of disease progression, activity, new complications, as well as response to therapy. So these are the following supportive treatments that we may use depending on the clinical manifestation of the patient. So for Raynaud's phenomenon, we may use these different calcium channel blockers, or we may add alpha-adrenergic blockers and a low-dose aspirin. Ischemic ulcerations, we may opt to give the patient or start the patient with endothelin 1 receptor antagonists such as bosentan. For musculoskeletal involvements, we may give NSAIDs as a first-line therapy, or we may start the patient with methotrexate or use low-dose steroids but with caution. For skin induration, our first-line treatment is the use of methotrexate as well as mycophenolate mofetil that is associated with modest skin improvement. We may also do autologous stem cell transplantation and D-penicillamine, which is an antifibrotic but nowadays are not currently used. So for GERD, we use proton pump inhibitors. Also, for domperidone, for those patients with delayed gastric emptying time because of decreased peristalsis, endoscopic laser photocoagulation is done in patients with GAVE or watermelon stomach, and short course rotating broad spectrum antibiotics, especially in those patients with bacterial overgrowth. The following treatments are given in those patients with pulmonary hypertension and interstitial lung disease. We may give cyclophosphamide and ACE inhibitors in patients with scleroderma renal crisis. So for our last topic, we now discuss mixed connective tissue disease. Mixed connective tissue disease is an overlap syndrome of patients with scleroderma coexisting with features of SLE, polymyositis, and rheumatoid arthritis. This is also associated with high titers of U1RNP. So for the other clinical features, patient may present with pulmonary fibrosis, pulmonary arterial hypertension, esophageal dysmotility, Sjogren's syndrome, and presence of renal disease, particularly membranous glomerulonephritis. These patients usually have elevated ESR and hypergammaglobulinemia. Scleroderma-specific autoantibodies as well as autoantibodies related to other disease entities are not found. And in contrast to scleroderma, patients with Mctd often show a good response to steroids and has a better long-term prognosis compared to scleroderma. So in summary, we have discussed the different clinical features, laboratory evaluation, and management of patients with idiopathic inflammatory myopathy, systemic sclerosis, and mixed connective tissue disease. Thank you for listening.